Right, good afternoon everybody, and welcome to this, which is the inaugural meeting of the NHS Commissioning Board Authority. I'm delighted to welcome my colleagues who are members of the board and our senior management team, but also to welcome those who are joining us this afternoon in the public gallery. Let me stress that this is a formal meeting of a statutory authority taking place in public. It's not a public meeting. But we will be transacting the initial business of the board. We're joined by Ed Smith on the screen, who is today in London, but has been appointed to the board as a non-executive director and also will be chairman of the audit committee. One of the tasks that we face in the next few weeks and months is to make other appointments to the board. But I'm delighted to announce this afternoon the appointment of Sir Bruce Keogh as Medical Director of the NHS Commissioning Board Authority. I'd like to start with a few words about this unusual new body and its great strategic importance. It is, first of all, a great privilege for me to have been appointed as the founding chair of the board, and to be appointed as somebody who has had for the last 8 years the responsibility for heading up a major research-intensive university with a significant biomedical and life sciences facility, and also with a very strong relationship with the NHS, not only through our immediate partner, which is the University College London Hospitals Foundation Trust, but also other leading teaching hospitals across London. The role of the board, as we see it, is to be responsible for ensuring that the NHS delivers better outcomes for people within the resources that are available, which are limited, as we know. And our determination is to make this board a champion for people and patients. Focus on what they want and what they need, and to be a board that is a professional organisation with strong clinical leadership, with very clear values, and with a distinct culture. But it doesn't exist on its own. It's going to be a body that will and must work in partnership with the clinical commissioning groups, with patient groups, with other interested parties, local authorities, unions, industry, existing and new NHS bodies such as Health Education England and Public Health England. It's going to be an immensely challenging task in difficult circumstances. But we start, I would say, from a very strong starting point. Earlier this week, there was the publication of the British Social Attitudes Survey with its annual question about the degree of public support for the NHS. This year disclosed that there was a level of support of 70% of the public who believed in the NHS, up from 34% in 1997. That is a spectacular increase. And I would say that it spoke volumes, not only for the additional investment that's gone into the NHS over that time, but also for the dedication of the staff who serve this national institution. And those are qualities that we need to build on as we take forward our work on the commissioning board. We are at the moment in a transitional stage. This is a commissioning board authority, which is a special health authority awaiting the final approval by Parliament of the National Health and Social Care Bill that's presently going through. Upon completion of those processes, the board can be established as a formal authority and take on in due course the powers under the new legislation. But we should be modest as we go forward, but to assure you that already a number of work streams are underway to ensure that there is a smoother transition from the historic model of the NHS to this new model where there is an independent board responsible for its day-to-day operational management and its strategic leadership against a mandate that will in due course be provided by the Secretary of State for Health. The challenges are enormous. There's not only the austerity of the current financial environment by comparison with the significant year-on-year increase in investment over the past decade in the NHS. There are the challenges thrown up by demographic change, by longevity, by increases in the cost of drugs and technology, and by some quite seriously adverse trends in public health, including, of course, abuse of alcohol, of drugs, tobacco, and obesity. None of these create a low-cost environment for providing world-class healthcare for the future. There are opportunities too, we believe, in releasing the potential of clinical commissioning, which lies at the heart of the work for which the board is responsible, for developing innovation and research, and you may be aware of the paper that was published on Monday by David Nicholson for the government on delivering innovation within the NHS. There are major opportunities, and opportunities to which I hope that I will be able to contribute by drawing more closely together those two great British institutions, the NHS and our universities. There are marvellous opportunities for closer collaboration and development of ideas. Above all, this board will be devoted to the overarching principle that the NHS is for people. It's for people, for patients, for carers, for communities, and for the NHS community of staff, as well as for the community more largely, to prevent ill health and to prevent people becoming patients through greater attention to the public health agenda. It gives me enormous pleasure, therefore, to open this meeting with a statement of great positive optimism about the work that this board can undertake, whilst appreciating how appropriate it is to be modest at this early stage and to understand fully the challenges that lie in front of us. It gives me a lot of pleasure to introduce our Chief Executive, Sir David Nicholson, to say a few words. David, over to you.
Hey, thanks, Chairman. And I absolutely concur with what you've been saying there. And as a kind of lifelong NHS manager, it's a great privilege for me to be the first Chief Executive of this independent board, where I hope we can start to take the health service forward in a way which can deliver great opportunities both for patients, the communities, and of course people who work within the system. I just want to talk a bit about the commissioning board itself, first of all, what it's there to do. And the first thing I think, which is the most obvious one, and it's reinforced by what you've said, and it's been reinforced by the work we've all been doing over the last few years, which is a relentless focus on improving outcomes for patients and communities. It seems to me that is really at the heart of what we need to do, and we need to do that through integrated care. That's what patients want. That's what the evidence shows us gives great quality and outcomes for patients. So how do we do that? What is the mechanism that well, obviously we need to build a commissioning board which has that focus, and I'll say a little bit about that in a while. But more importantly than that, we need to help support and build a clinical commissioning system, which starts not with the commissioning board, but starts with the individual practice. The individual practice, with its close connection with local communities and population, you build on the back of that the clinical commissioning groups, where you can bring together clinicians of a variety of backgrounds, together with patients and local government, to enable you to look at the health needs of the population and translate those into services for patients. We need to build that on the clinical networks, the great networks we've got developing cancer services or coronary heart disease. We need to extend those and develop them, and of course building on the wider clinical community in terms of the development of senates. So all of those things are about building the power of clinical commissioning. That, it seems to me, is the distinctive characteristic of what we're trying to build in this new NHS as we go forward. And it's that clinical commissioning, the connection between evidence, clinicians, and the direct connection with patients is the thing that's going to make the difference. And if we see the commissioning board as supporting and helping that, as opposed to some kind of supervisory body, I think we've got a really big chance of building something new and not reinventing the old. In terms of the commissioning board itself, we want to design it around the outcomes framework. So instead of an organisation which traditionally might have been organised around professional responsibilities, we want to build it around the outcomes. So we want to build it around the potential for reducing mortality, the potential for improving the individual care that patients will get on an episodic basis, to improve the quality of life for people with long-term conditions, giving them more power and responsibilities, for improving patient safety and for improving experience. All of those things need to be built into the way the new organisation operates, and that's the way we want to plan and organise it. So we see clinicians absolutely at the heart of the way the commissioning board operates. But we've also got major responsibilities in relation to ensuring that the NHS can improve services, but within the resources available. So the highest level and quality of management, both general and financial, will be critical to our success. Many people, some people have criticised the quality of management generally in the public service. I think we can be justifiably proud of the quality of management in the NHS, and using that to best effect as the commissioning board is going to be a really important part of what we do. So I think this is a really important moment in time for starting to build that clinical commissioning system which can improve outcomes for patients and the population, and make sure that as we go into increasingly challenging time in relation to resources available, that we genuinely can continue to improve quality at that period.
Thank you, David.